I was asked to prepare a case for the meeting, and I was thinking about it for 2 or 3 weeks. And then last week I was on for the ICU, and I didn't have to prepare anything anymore because it came to me. And this is very real, and that's just about 10 days ago. So this is a 79-year-old woman who is admitted to hospital electively for insertion of a permanent pacemaker. She has a history of paroxysmal atrial fibrillation, and she has been treated by a cardiologist with amiodarone and beta blockers, namely nebivolol. And over the last few weeks, she's had a couple of episodes of bradycardia, and the cardiologist has decided that the only way that they can control rates and not have bradycardia is to have pacing inserted. This lady has a history of hypertension and has a moderate cardiomyopathy with an ejection fraction of 35% and no evidence of significant coronary artery disease on angiography, and the cause of her cardiomyopathy is unclear. This is the photo I took with my mobile phone of her ECG. It's just there to show you that she has got a left bundle branch block and a pattern consistent with that, and very deep Q waves consistent with LVH on the ECG. When she presents for her permanent pacemaker insertion, she complains of having been short of breath on exertion in the previous few days. Her heart rate is about 90 to 120 beats per minute in atrial fibrillation. She's on 2.5 milligrams of nebivolol and 200 milligrams of amiodarone twice a day. Her blood pressure is 160/90 on admission. Her respiratory rate is 18 at rest. She's noted to have bibasal crackles, and she's afebrile. She complains also of having mild dyspnea when lying flat, and also of some upper abdominal bloating and discomfort. A chest X-ray is done, which shows a very small right-sided pleural effusion. Prior to pacing, a few days before, as an outpatient, she had an echocardiogram done. It showed that she had significant diastolic dysfunction, that she had left ventricular hypertrophy, and also mild to moderate global systolic dysfunction. Her left atrium was dilated. Her pulmonary artery pressure was estimated at 44 millimeters of mercury plus right atrial pressure, and the ejection fraction was estimated somewhere around 35%. A global longitudinal strain was at minus 9%, is considerably abnormal compared to normal values. Other than the nebivolol that we talked about, she was on amiodarone, on rivaroxaban for her atrial fibrillation anticoagulation, on spironolactone, 25 milligrams twice a day, on furosemide, 80 milligrams MANE, and 40 milligrams in the afternoon. She had a full blood examination, which was normal, and her serum creatinine was 112 micromoles per liter, and the liver function tests were normal. So that's May 31st, so it's a couple of weeks ago. She had a dual-chamber pacemaker inserted, and the procedure was uncomplicated. She was kept under observation in the cath lab for a period of time. She was afebrile. Her heart rate was 110. Her blood pressure was 150/80. The respiratory rate was 18. No tests were ordered. And after pacing was inserted, the nebivolol was increased to 2.5 milligrams twice a day to help control a heart rate now that she was paced. The following day, I think it was a Saturday, the patient was in the cardiology ward. She had a temperature of 37.4, a heart rate of 100, blood pressure of 140/70, respiratory rate was 20. She spent most of the day in bed. She went to the restroom and the bathroom and complained of some dyspnea on exertion and continued to complain of upper abdominal discomfort. She was examined. She was not tender on examination. She had some crackles on the right side. And because of the abdominal pain, the cardiologist ordered a lipase, which was 25 international units and totally normal. The creatinine, however, was now 127 micromoles per liter instead of 112. A midstream urine was sent, which did not grow any bacteria and had no white cells. And as I said, the abdominal examination was relatively bland with some deep palpation-induced discomfort, but not much of anything else. The cardiologist decided that an ultrasound of the abdomen should be performed in case the patient had some gallbladder disease. And this was done, and it was considered unremarkable. A decision was made not to do a CT of the abdomen because the patient was well, and there was concern about the risk of radiocontrast given her serum creatinine. She had a slight temperature, as I said. There were the crackles in the chest, and she was referred to a pulmonologist. The pulmonologist came, and he ordered an abdominal X-ray. And the abdominal X-ray showed mild distension of the colon, some moderate fecal loading in the sigmoid, and no other findings. The pulmonologist also ordered a high-resolution CT scan of her chest. And the high-resolution CT showed mild congestion, a small right-sided pleural effusion, and bilateral areas of mild basal atelectasis. Nonetheless, doxycycline was started. It's June the 2nd. She's not feeling well now. She's sweaty. She's a bit cool in the periphery. Her vitals show a temperature of 37.2. A heart rate is 110. A blood pressure is 140/70. Respiratory rate is 20. She continues to complain of this upper abdominal pain, and nobody can kind of sort out what's going on. Again, the physical examination remains unremarkable. She is reviewed by a cardiologist, and a diagnosis is made that she has abdominal discomfort from constipation, and she is started on laxative therapy. She's also reviewed by the electrophysiologist who inserted the permanent pacemaker, and a decision is made to increase the nebivolol due to persistent, poorly controlled heart rate above 110, and so she's now on 2.5 in the morning and 5 milligrams at night. June the 3rd is Monday. And the patient complains of not feeling well. She's noted to be sweaty, still complaining of abdominal pain. The temperature is normal. The heart rate is now slowed down, and there are a few pace beats coming through. She's still in atrial fibrillation, of course, and the permanent pacemaker rate is set at 60. The blood pressure is 120/70. The respiratory rate is 22 and a saturation 97%. A full blood examination is ordered by the cardiologist. It's normal. No liver function tests are done. And the creatinine now has increased to 155 micromoles per liter. Louis, you're a nephrologist, aren't you? Rumor has it. So what's going on? Why is the creatinine going up? Very good. I think I would probably ask them to carry on doing the CT scan, not just right. I'd like to see a blood gas, particularly a lactate. Well, that's very nice.
And rather than a lactate, I've got a microphone, which is probably even more useful. So that's what I would ask for.
You like to know a lactate. That sounds very nice. You like to do a CT scan of the abdomen. That's very nice. Would you give IV contrast when you would do such a test?
Yes, I would.
Yeah, okay.
After doing a non-contrast first.
Sounds good.
Yeah. So, if let's not get
That's
into
good.
the
John,
intricacies
what do you think? What do you think? Do you think that's fair, or do you got any comments? Or
As much as it pains me, I have to agree with Louis. I think that we need to know the answer. No, I think that's right. I think that's where that follows Sutton's law, I think, and there may be a little bit of a risk of contrast, but I think there's a bigger risk. The biggest risk for this lady is for her to languish in the hospital for a few more days without a diagnosis.
That sounds very reasonable. Any comments from the audience? Any questions? This is the real world out there. So, however, she's reviewed by the cardiologist. She is noted to have a low jugular venous pressure, at least that's what's reported. She's noted to have this rising creatinine. A chest x-ray is repeated, which shows no change. And the cardiologist notes that given the low jugular venous pressure and the rising serum creatinine, this patient may be dry. That's what was written in the notes. And so furosemide was decreased from 80 in the morning and 40 in the afternoon to just 40 milligrams mane. No other actions were taken. Mick, what do you think? A cardiologist. She's been seen by a pulmonologist, a cardiologist, and an electrophysiologist. She's seen 3 clinicians. Now, it's June the 4th. By the way, I don't know anything about this lady, right? I'm just happy in intensive care doing my stuff. So now it's June the 4th, and she's complaining of not feeling well. She is sweaty. She's noted to have cool hands. And she complains to the nurse that she really hasn't passed any urine since last night. And she is continuing to complain of this right upper quadrant discomfort, which seems not to have gone away. And the family are worried, and it just seems to be there all the time. On physical examination, she has no temperature. Her heart rate is 60 to 65 with occasional pace beats. The blood pressure is 120/70. Respiratory rate is 22. Saturation is 96%. A full blood examination is repeated, and there are no abnormalities. No liver function tests are done. And the creatinine has now increased to 167 micromoles per liter. John, what should we do now?
Has anyone considered maybe a bladder scan or anything like that?
Not at this stage.
She doesn't have a Foley catheter.
Nope.
Yeah.
It's pretty scary stuff, isn't it? Any comments from anyone? Any questions? But this is happening. So I don't know anything about this lady. I'm still kind of. So serum lactate, blood gases, screaming out, but they're not happening. Not happening. It's very, very reasonable comments. She's reviewed by the cardiologist the next morning. The patient is still complaining of abdominal pain. She's still sweaty. Now she's kind of irritable. She's kind of, like a little bit aggressive. She's normally a placid kind of individual, but she's not happy now, and she refuses to take her tablets. Her vitals are measured again, and it's about mid-morning, and they are as displayed. And again, she complains that she just hasn't passed any urine at all since last night. And a serum creatinine from the morning labs comes back at 197 micromoles per liter. This is going on. So at about 4 o'clock in the afternoon, the patient tries to get out of bed, go to the toilet, but feels really faint and dizzy. The nurses arrive and they put her back into bed, and they start doing vital observations. And She's still afebrile, but now her respiratory rate is about 30 breaths per minute. Her blood pressure now is about 60 to 70 systolic. Her heart rate is slow at about 60. The saturations cannot be obtained because she's got a very cold periphery and she is confused. So now they activate the medical emergency team. The medical emergency team goes to see her. And they arrive and they note that she has ice-cold extremities. That she's clammy, shut down. They can barely feel the blood pressure. The patient is drowsy and she has mottled skin everywhere. They start oxygen therapy. They insert an intravenous line. They give a bolus of metaraminol, which is a vasopressor agent, to restore a blood pressure to a survivable level and immediately transfer the patient to the intensive care unit. And that's when I get a call that this lady is arriving. And I said, oh, okay, that's interesting. On arrival, she's complaining of abdominal pain. She's tender on palpation. She's now on a norepinephrine infusion given peripherally. She has 500 mils of 4% albumin being given as a bolus to help sustain the blood pressure, and an emergent central venous access and arterial line are inserted in her groin under ultrasound. Arterial blood gases are obtained, and they are as displayed. Her pH is 6.95. Her lactate is 17 millimoles per liter. Base excess is minus 18 milliequivalents. Her PCO2 is 38, and her PO2 is 96. Mick, what should we do now? Yes. Yes. So this is a dramatic situation. John, what do you think the diagnosis is?
Well, it could be any number of things.
Of course.
We have anything back in terms of even a hemoglobin?
No, good. So the hemoglobin is with the blood gases, and it's about 110 grams per liter. It's unremarkable. Yeah, she's not bleeding.
Okay.
No.
So what about that Foley?
So she's had right upper quadrant pain for a week in the hospital,
Yeah.
and no liver function tests and no abdominal CT scan.
And no CT. No, it is true. Yeah, it is true. Sorry, you made a comment.
What about that Foley?
That hasn't gone in yet. There's people who are just busy keeping this woman alive right now. So we think we should do a very quick bedside echo because, she's at a permanent pacemaker. We think, she was in rivaroxaban, is this some catastrophic iatrogenic thing? I just put the thing on, make sure she's not tamponading and that she's not being progressively, relentlessly accumulating blood in the pericardial space. So she has a small non-dilated right ventricle. She has no pericardial fluid. She's got a poorly contracting left ventricle, minimal MR, minimal TR, tests sent off. The ECG is unchanged. We start on Murinon infusion because we make the diagnosis that she is in cardiogenic shock. And we have norepinephrine to maintain a mean blood pressure above 65. We give bicarbonate loading, and obviously at this point, with a lactate of 17, we think she's got ischemic gut, or ischemic liver, or both. So it just so happens that the patient arrives while a vascular surgeon is examining a patient in the unit that's a vascular patient. And we have a discussion, and then he says, look, this is not my field. He calls a gastrointestinal surgical colleague, and there is one in the hospital, and he comes to see the patient. And he says, look, the situation is dramatic. She could have ischemic gut. You could do a CT scan, but she may not survive the trip to CT scan. I think we should take the patient and have a laparotomy. and he speaks to the family about prognosis, as we all do. Do you think that's the right thing to do, Louis? Okay. Of course.
The gut dies from the inside out. So I've seen situations where the gut looked normal and the patient came back to the unit, got worse, went back to the OR, and then the gut was black. So I would have still said I'd want the CT scan before to go to the theatre.
He's a good clinician, isn't he?
Yeah.
He's
So-
all right. He's all right. He's all right. The Brits are not that bad. Go for it. Sorry.
So, no, I was just going to say at my center, we'd put her on ECMO first and then send her to the OR.
Oh, that's cool.
I think ECMO's coming. But that's...
Marlies, any comments from a British intensivist? Can't just let Louis hog the day.
So in our institution, we've seen quite a lot of false positive CTs where people were diagnosed with gut ischemia, even gut perforation, and when they were taken to theatre, actually, or sometimes we didn't take them to theatre and they miraculously recovered with just good resuscitation. So a CT, I am saying, I disagree with Louis here. CT is not always conclusive, and
So, no, you
may
can't-
give you,
you know.
may put you in the wrong, lead you on the wrong track.
I agree with both. You can't win.
Yeah, but no,
You can't win.
I think you should do CT, then go to theatre. I think that's actually what I think.
Any comments? Any other comments? Well, the patient's taken to the OR urgently. The abdomen is opened, and to make Louis very happy, there is no surgical evidence of gut ischemia. However, the liver function tests come through as the patient is in the operating theater, and the LDH is 6,500 and the AST is 1,800. The INR is 4.9, consistent with ischemic hepatitis. The glucose is now down to 3.9, also having a degree of hypoglycemia, consistent also with ischemic hepatitis. So a lactate is still 17 when she returns, and we make a tentative diagnosis that she has ischemic hepatitis secondary to cardiogenic shock, but we don't know why this woman has cardiogenic shock. Any volunteers why this woman, who was at home, has not had a troponin rise, does not have tamponade, is in cardiogenic shock this afternoon and has been progressively working her way into full-blown cardiogenic shock. Endocarditis, well, the echo is unremarkable. Endocarditis for 3 or 4 days, and why would that happen? There is nothing on echo. Sepsis inducing cardiogenic shock, normal full blood examination, doesn't really afebrile all the time, doesn't make me happy. Yes. Yeah, I like that a lot better. Beta blockade induced oblivion. Yeah, I believe that. So we looked up nebivolol because it's kind of interesting because, you know, we did a crime scene investigation at this point because I'm saying, what the hell is going on? And there was a pattern in my mind because over the last 15 years, I've seen about 2 or 3 people with sotalol-induced cardiogenic shock in the setting of worsening renal function because sotalol is renally excreted. And it turns out the nebivolol kind of isn't, except that its metabolites all are, and they're all metabolically active. And in the history that I've told you, there's been this progressive increase in nebivolol to block her heart rate. And I don't know, I can't prove it, but there was nothing else. We don't have a troponin rise, we have no chest pain, there's no tamponade, and watch what follows. So we think that she's got beta blocker-induced myocardial failure, and so we try to bypass it with milrinone. We monitor a cardiac output flow track, alter the pacing to 100 beats per minute. She's some bleeding from her nose. We put her on broad-spectrum antibiotics because we can. And over the next 8 to 12 hours, the skin mottling disappears. She's got warm hands with great capillary return, obeys commands. The norepinephrine is gone, melted away. We continue the Mirinone. Blood pressures come up, and it all looks lovely. The lactate has gone down. We haven't started hemofiltration, all right? The lactates come down to 3.3 millimoles per liter. The LDH is coming down. The AST is coming down. We've got our own antibiotic cover, and we're kind of happy. This is cool. This is kind of fits into our prejudices that this is a beta blocker thing. We put it on Mirinone. The cardiogenic shock is getting better. So this was the afternoon, the morning. She looks great and continues to remain stable. But at 3 o'clock in the afternoon, all of a sudden, her blood pressure declines rapidly. She's back on norepinephrine. There's no mottling. The periphery is warm with good capillary return. The cardiac index seems to be okay. The hemoglobin is stable. The liver enzymes are falling, but now the lactate is going up again. So the cardiogenic shock picture is kind of gone, but now there is vasodilatation, hyperlactatemia coming on. And within 2 or 3 hours, she's on 40 micrograms or norepinephrine. Louis, what do you think's happening?
Yeah, I've finished my shift and I've gone home now.
Now, Louis, I think what's happening is that you were right. I think that's what's happening. I think you're right. The gut was ischemic.
Exactly. I mean, I think that's what you're worried about is you've missed something.
Just
so
couldn't see it.
Either it's something intermittent, which I don't like in medicine, but you do see occasionally, a shunt that we can't quite explain, or you missed it in the first case. So you've treated it initially, eased back, and then it's reared its ugly head.
Yeah, we think we're reperfused in ischemic gut.
Exactly.
And we have, where is Massimo? We need endotoxin removal. So she's still warm. There's no evidence of cardiogenic shock. We've now got massive vasodilatation. We started on full pressor support. We expand the antibiotic cover, add antifungal, speak to the family. And now, by 9 o'clock, she has profound refractory vasodilatory shock. And we speak to the family and agree to withdraw treatment. And she's given narcotics, norepinephrine is stopped, and she proceeds to die. That's real stuff. So the moral of the story is single organ doctors are really dangerous. They are really dangerous. They focus on one thing and keep on focusing on one thing. Even in Australia.